Good afternoon, and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. I would like to welcome all of you to the Empowerment and Self-Management of Diabetes, the Pharmacist and Diabetic Care Learning Collaborative, session number 3. We are going to discuss the diabetes management for our senior population. Next slide. This is a live activity. At this moment, our lines are muted. At the end of the webinar, we are going to have a Q&A session. So if you have questions or if you have some questions, please use the chat box and type your question, or use the raise hand icon and your line will be unmuted. There is a handout that you can download from GoToWebinar. You will have the slides for this session. And later, after this webinar, you are going to receive an email with additional resources and materials related to this discussion. Next slide. We are funded by HRSA to provide training and technical assistance to community health centers. And we work closely with those health centers located in or immediately accessible to public housing. Next slide. Before we get started, we are going to discuss just some public housing demographics. Based on the content of this presentation, is very, very important to note that 38% of those living in public housing have at least one disability. And even though it's not part of this slide, 16% of those living in public housing are seniors or over the age of 65. This is the reason why we believe this topic is very important, because of the demographics in public housing and the prevalence of diabetes in the aging population. Next slide. The issue of diabetes in health centers is a big issue. In fact, this is a HRSA priority, and all health centers are working on improving diabetes control and diabetes management. 32% of those patients served by health centers, according to 2018 UDS data, have uncontrolled diabetes or an A1C greater than 9. Next slide. In addition, those living in public housing have other chronic medical conditions that can exacerbate diabetes. 71% of those living in HUD-assisted housing or receiving HUD-assisted programs reported to be obese, have almost 14% have COPD, and around 16% have asthma. So this is very important, and if you see the numbers or the percentage of those receiving HUD-assisted programs, almost 18% of them have diabetes, which is almost two times, higher than the general population. Next slide. So it is my pleasure to introduce Terry Lawson, who will be conducting this session, and who has conducted the previous sessions, the two last sessions. So I will turn it over to you, Terry. Good afternoon.
Good afternoon, Doctor, and good afternoon, everyone. We're going to be discussing diabetes management for our senior population, primarily through the pharmacist's eyes. Discuss the prevalence and pathogenic characteristics of our older population, discuss the comprehensive assessment and factors to consider in our seniors, discuss the framework for treatment goals for glycemia, blood pressure, and dyslipidemia, discuss the recommendations regarding pharmacologic therapy in our seniors, and discuss the rationale for treatment regimen simplification and de-intensification and de-prescribing in our older adults, and discuss simplification of complex insulin therapies. Next slide, please. Approximately a quarter of our senior population have been diagnosed or are undiagnosed with diabetes, approximately 14 million seniors. 1/3 of them are undiagnosed. And we're expecting an increase, a rapid increase in prevalence in the coming decades. Our older adults with diabetes have higher rates than those without diabetes in premature death, functional disability, accelerated muscle loss, comorbid conditions like hypertension and coronary heart disease. And projections suggest that we're going to see at least a 4.5-fold increase in the coming decades. Next slide. The incidence of diabetes increases with age. It is still a disease of aging, and about age 65 years, after which both the incidence and the prevalence seem to level off. Long-standing disease in older adults that have incident disease or long-standing diabetes, we're seeing an onset in middle age or earlier than that. They have the highest rates of major lower extremity amputations, myocardial infarctions, visual impairment, end-stage renal disease of any age group. And as they get older, they have higher rates of most complications. Deaths resulting from hyperglycemic crises also are at a higher rate. Type 2, okay. And deaths resulting from hyperglycemic are also significantly higher in the older adult population, and those aged 75 and older have double the rate of emergency department visits for hypoglycemia than the general population with diabetes. Next slide. So type 2 is overwhelmingly the most common incident type of diabetes in older age groups, and older adults are at a high risk for the development of type 2 due to the combined effects of aging, which causes an increase in insulin resistance and impaired pancreatic function. They're at a greater risk than older adults without diabetes for several common geriatric syndromes, among them polypharmacy, which pharmacists were very familiar with, cognitive impairment. They have a decline on activities of daily living, depression, urinary incontinence, falls, and persistent pain. These conditions can impact their self-management abilities and their quality of life if we leave them unaddressed. Next slide. So assessment of medical, psychological, functional, or their self-management abilities, those social geriatric domains that we just discussed, provide the framework for us to determine what targets and therapeutic approaches are reasonable for our patients. The older adults with diabetes are at a higher risk for cognitive decline and institutionalization. They have a higher incidence of all-cause dementia, Alzheimer's, vascular dementia than people with normal glucose tolerance. Longer duration of diabetes is also associated with worsening of that cognitive function. The dysfunction makes it difficult for our patients to perform their self-care tasks, such as monitoring their glucose. It hinders their ability to appropriately maintain the timing of meals and content of their diet. And identifying cognitive impairment is really important as early as we can identify it. Next slide. So screening, as I said, is in early detection is really critical for our older population. The guideline states for psychosocial conditions, we need to screen for depression, anxiety, disordered eating, and we need to consider referrals that are needed to be done and consider assessment for cognitive impairment. When we're managing our patients with cognitive dysfunction, it's critical for us to consider the simplification of the drug regimens and facilitate and engage the appropriate support structure to assist the patient. I've included a handout. It's a mini cog. It is an assessment tool that I used to use in my practice. It takes about 10 minutes or less. An assessment, of course, can be performed by us, and it should be performed at annual Medicare annual wellness visits. Next slide. Some red flags that we can look for cognitive function is the significant decline in clinical status. If we notice that they're having difficulties with self-care activities, calculating insulin doses or counting carbs, if they're starting to skip their meals, or more importantly, their medication doses for us, and also not able to recognize hypoglycemia, we really need to consider hypoglycemia unawareness in this population. And we need to consider referral to behavioral health for those that screen positive. Next slide. Cognitive decline, as I mentioned before, is associated with increased risk of hypoglycemia. And severe hypoglycemia has been linked to an increased risk for dementia. So it should be avoided at all costs in our older population. And it should be used to assess, minimize, and manage our glycemic targets and pharmacologic approaches. Next slide. Interaction with coexisting medical conditions negatively impact their ability to self-manage, and it increases the risk of fractures. Avoidance of severe hypoglycemia and hypoglycemia can decrease the risk of falls in this population. Peripheral neuropathy does impact significantly to the limiting physical activity for them. It increases the risk of falls. It's present in 50 to 70% of this population. It can cause gait and balance issues, and of course, we also have muscle atrophy associated with it. Comorbid conditions also increase the risk of falls. And I've also included a handout here. It's a booklet on annual wellness. The fall scale needs to be used on annual well visits, and pharmacists are performing more and more annual well visits with this population. And physical therapy is also something that should be encouraged in patients who are at high risk for falls or have recently fallen. Next slide. Sarcopenia, or reduced muscle strength, it's poor muscle quality, and it's associated with accelerated loss of muscle mass. So that makes it really, really important for this population to be well nourished, that they incorporate exercise that include aerobics. Some resistance training is encouraged. Our older adults are at a higher risk for undernutrition, primarily due to anorexia. They have altered tastes and smell abilities. They have swallowing difficulties. They have dental issues and functional impairments that can lead to underperforming and preparing their food. I've also included a handout here, the mini nutritional assessment. It is something that they can self-administer, or you can even help your patients through the questionnaire, but it helps identify who may benefit from a referral to a dietitian for medical nutrition therapy. I've also included the link here for you. Next slide. Recommendations should consider the patient's culture, of course, their preferences, their personal goals and ability. When nutritional needs are not being met with usual intake, we should intervene here, encourage perhaps some smaller frequent meals throughout the day, fortify their usual foods, Changing the food texture may help, or adding a liquid nutritional supplement may also help in between meals. And more, very, very important, is to identify those community resources such as Meals on Wheels and senior centers, and the U.S. Department of Agriculture Older American Nutrition Program may also help as a resource for you. Next slide. I've included a handout here from HHS. It's making physical activity a part of an older adult's life. I've also included the link here. It's a very extensive document, but it has a lot of helpful information for our older population. AARP, we've all heard of them. They have wonderful resources, including exercise options for our senior program. You can also find a program through Medical Guardian. Some of them are here: Healthy Sneakers, Enhanced Fitness, and the Wise for active older adults. And they all should include some form of walking, dancing, some sort of aerobic activity, some sort of muscle strengthening activities. Gardening is in here. A lot of them still love to garden. That is a great option for our older adults. And incorporating some sort of balance training is also very helpful for our patients. If you have a patient that needs weight loss, then strategies that combine physical activity with nutrition can promote weight loss in this population and improve their cardiometabolic profile. Next slide. This is from the International Council on Active Aging. I wanted to highlight this because you can actually look for the type of resource that you're looking for your patients. So as I put here, that's what would be present in the drop-down. You could look by fitness center, retirement living, community services, recreation centers, as well as YMCAs that offer the Wise for older adults. And you can look by state or zip code. Next slide. Persistent pain and neuropathy, of course, are other considerations that we need to look at in this population. It does impair their functional ability. It increases the risk of falls, and basically, it's something that can overwhelm the patient. It's something that needs to be assessed and looked at, and resources identified for them. We always need to rule out hyperglycemia, especially in the presence of urinary incontinence, which is very, very common in our older adults. So that's something that if you have an individual that's urinary incontinent, always ask the proper questions and assess and evaluate the patient for hyperglycemia by using their blood glucose readings. Next slide. Patients over 60 years of age consume 50% of our dispensed prescription drugs. Our average adherence decreases from approximately 80% in patients taking medication once daily, and it goes down to 50% in those medications being taken 4 times a day. Polypharmacy actually increases the risk of drug side effects, as we all know, drug-drug interactions, duplications of therapy, but it's more than likely intentional and necessary, right? Because a lot of our patients have comorbid conditions that need to be treated. It's just up to us to identify where we can simplify, where we can reduce risk, especially when it comes to falling. For example, some side effects we need to look at are from blood pressure medications, syncope, dizziness, and sedation from medications that we use to treat urinary incontinence. Cost is always a big issue. We're dealing with a population that has a fixed income. They could be dropping off into the donut hole. So cost, whether insured or not, is always an issue in this population. Next slide, please. I've included a handout here. It's an article from Pharmacy Times, adherence issues in elderly patients. And these are some of the reasons that are pointed out in that article. I've already touched upon these mostly, but medication reconciliation and ongoing assessment and indications for each medication is required. And always assess for medication adherence and any barriers or new barriers that are popping up in your patient. You see cost here, risk to benefit. Do they perceive that the treatment is necessary? That's a very common one. Complexity you see here, so the easier the regimen for them, the better outcome you may see in these patients. As far as pain medication, they did point out that they are fearful of addiction. And of course, you see cognitive decline, which is associated with the aging population. Next slide, please. Life expectancy and health status, how sick is your patient, is where we should be focused on. So obviously our individualization of our glycemic targets relies really on how the patient is doing, how sick are they, how many medications are they taking, what is their life expectancy. So if their life expectancy is low or they have multiple chronic issues that they're dealing with, the lower our stringency should be, right? We shouldn't be so tightly tied to that below 7%. So we go higher in the A1C category there. Next slide, please. So as I said, health status is important. So if you have an older adult that's otherwise healthy with few coexisting chronic illnesses and intact cognitive function and functional status, you can actually target an A1C around 7.5. If you have an individual that has multiple coexisting chronic illnesses, you have an individual that's cognitively impaired or functionally dependent, you should be less stringent with those glycemic goals, around 8 to 8.5. Always, of course, avoid hyperglycemia. Acute complications should be avoided in these patients, and screening for those complications should be individualized in our older adults. A particular attention should be paid to the complications that would lead to functional impairment, such as visual or lower extremity, wound care, foot care. Next slide. Here you have the spectrum, of course, of complexity. As I mentioned before, the healthier your patient is, the more stringent you can be. I hate to use stringent, but less strict with the A1C. The more complex, the looser our stringency should become. As far as blood pressure is concerned, you know, we don't really want them too low. That can increase their risk of syncope, their risk of falls. And the statin, always consider the risk to benefit. Obviously, if they're very complex, evidence supporting the value here is really not there. So always individualize your treatment, use your clinical judgment, of course, and self-management knowledge and skills should always be assessed in this patient population, especially if you're starting to see their functional abilities diminish. Next slide. Of course, we have an increased risk of hypoglycemia. We have multiple medications on board, so we have to be vigilant with adverse drug events. We need to be vigilant that they have pharmacokinetic and pharmacodynamic changes going on. They're more susceptible and sensitive to side effects. Overtreatment is common in diabetes, so medication reviews regarding polypharmacy, of course, are essential. Our focus and strategy in de-intensification or simplification of complex regimens is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved within the individualized glycemic targets that for our patient. Always consider the cost, as I mentioned before. Overburdening with increased costs increases the likelihood of treatment failure and non-adherence. And remember that in older adults are commonly associated with low health literacy. So you may consider assessment of their literacy with the realm with a nutritional label, for example, where you could see how well do they understand the numbers on a nutritional label, and always at the onset of every treatment. Next slide, please. Metformin continues to be our first line, even in this population. It's oral, it's less complex. If it's not contraindicated, it is the way to go. Very simple drug, very good reputation. We do have to watch lactic acidosis in this population, especially if you're seeing hepatic dysfunction or congestive heart failure. And always, always, especially upon initiation, watch out for those GI side effects. Although they are limited, they should go away. But in this population, we really need to take a look at their nutrition and how well their appetite is. TZDs, we should always use caution. Those with or at risk of congestive heart failure, osteoporosis, falls and fractures, bladder cancer, or macular edema have been seen. Secretagogues like sulfonylureas, we should always use extreme caution. They are a very high risk for hypoglycemia. If at all, if we're going to be using them, try to use the shorter acting ones like glipizide or glimepiride. Next slide. Incretin-based therapies, just consider the cost and self-management ability for injectables here. DTP4 inhibitors have few side effects. They are oral and they have a low risk of hypoglycemia. GLP-1s, with the exception of semaglutide, are all injectable. They do require functional ability and ability to inject. You should avoid in people that are experiencing weight loss because of their associated GI effects. SGLT2 inhibitors are oral. They are extremely costly, just as GLP-1s are. They have demonstrated cardiovascular benefits among patients. And we do need to look at our patients with respect to volume depletion, genital infections, and urinary incontinence, which, as I mentioned before, is very common in older population. Next slide. As far as insulin, we know that you do need a functional abilities here and a good support structure if someone is assisting them. Requires that their caregivers also have good visual and motor skills if they are in fact helping them. The pens are easier, but more expensive. Insulin, as we know, very high risk of hypoglycemia. We're usually focused on nocturnal glycemia, but we should be focused overall on it, but we're very, very fearful of that nighttime occurrence. Once daily basal insulin injection therapy is associated with minimal side effects, however, and it may be a reasonable option in some patients. Multiple daily injections of insulin may be way too complex in this population, especially with advanced diabetes complications and life-limiting coexisting illnesses. Next slide, please. So a tailored plan is very, very important. You should base it, again, on health status, as I mentioned before, patient preference, functional status, comorbidities, life expectancy, and social support. Quality of life is very important in this age group, and independence is very important to our seniors and important for us to focus on. What is their living situation? Are they living alone? Are they living with family? Are they in assisted living or in nursing homes? So that should impact our valuation and assessment as well. Do they have caregivers? Are they living with someone that is caring for them? And shared decision making is always a really, really good way to go to balance the discussions between your patient, caregiver, and yourself, and it provides a clinical focus in the discussion. Next slide, please. So de-intensification of regimens in patients taking non-insulin glucose-lowering medications can be achieved by either lowering the dose or discontinuing some medications, so long as the glycemic target is maintained. You can lower, for example, glimepiride from 4 to 2 or discontinue it altogether, especially in the presence of hypoglycemia. And studies have shown that de-intensification is safe and possibly beneficial for our older population. When patients are found to have difficulty with complex insulin regimens, lowering the dose is not sufficient. Simplification of the insulin regimen without worsening glycemic control is what has been shown to reduce hypoglycemia and disease-related distress. So always match the individual's self-management abilities with the regimen and consider their available social and medical support systems and caregivers here. Next slide, please. So simplification refers to decreasing complexity of the regimen. So fewer injections, fewer administration times. Don't burden the patient with calculations and all of that. De-intensification and deprescribing refers to decreasing, for example, the dose or frequency of administration or of the treatment, or discontinuing a treatment altogether. So as we spoke before, the healthier the status, the lower the target can be as far as the A1C is. The more complex the patient is, going all the way to end of life here, the less stringent it should become. And at the end of life, of course, we're just looking at their quality of life, their comfort. What can we do to make them more comfortable? So if they're taking a medication that doesn't have a clear indication or benefit to the patient, it should be discontinued. With the rest of the group here, you're looking at, do they have severe or recurrent hypoglycemic events? Have they been recently hospitalized? Have they acquired cognitive dysfunction? Is it declining? Have they suffered a stroke, for example, that has caused functional inabilities in the patient? So it's a change process, and it goes with how well or how bad your patient is doing as to whether or not to consider simplification or de-intensification of the regimen. Next slide, please. So here we have a patient. Her name is Maria. She's 72 years old. She is Hispanic with very limited English. Her A1C is currently 6.8%. Her medical history is hypertension, hyperlipidemia, osteoporosis, urinary incontinence. She was hospitalized for hyperglycemia, and insulin glargine 20 units daily at bedtime was added to her regimen in the hospital. She lost her husband 2 months ago. You're seeing her after 2 weeks of being discharged upon referral of a primary doctor for medication management. She presents 2 weeks worth of blood glucose readings, 5 of which are below the 70 milligram per deciliter mark. The rest are within range. Her mood is very teary. She appears distressed over her situation. She reports adherence with all of her medications, but doesn't like the needles. She explains that after her husband passed away, she would typically forget to take her medications, especially those that were supposed to be taken multiple times a day. She also has a history of falls. She's fallen 2 times in the last year that did not require a hospitalization. She has also lost 10 pounds since her husband died. Her LDL is 65, her HDL is 37, her BP is 115/80. Her current medications include metformin 1000 BID, 20 units of glargine at bedtime, 40 milligrams of atorvastatin daily, 10 milligrams of lisinopril daily, alendronate 7 milligrams weekly, ditropan 5 milligrams, TID, and of course the insulin syringes. Next slide. And here's our poll question. What medications would you target for de-intensification with respect to her diabetes treatment plan? So, okay, all of you picked insulin glargine. Let's discuss. Next slide. Okay, back one slide. Well, that one. Thank you. So we have hypoglycemia here, right? So, and her A1C is 6.8, and she has multiple readings below range. So definitely, I would definitely discontinue the insulin glargine and bring her back to pre-hospitalization regimen with metformin. We have a complex individual here. She's got multiple chronic illnesses, cognitive decline after an acute illness, and she has had a significant loss. So that's something that really we need to target or focus on. I would go with an A1C closer to 7.5 here, even closer to 8 might be reasonable. And a cognitive assessment is definitely warranted here, and referral to behavioral health to address her depression and for continued support. She has a patient preference, so she doesn't like the injectables. I would definitely not go with an injectable in this patient. Other potential adverse effects to look at are her increased risk of falls and fractures. She has a history of osteoporosis, and she's had 2 falls in the last year. I would definitely consider and assess syncope here with this patient. Her blood pressure is 110/75. I would feel more comfortable with her being a little towards 140/90, and I would definitely consider the reduction of the lisinopril dose if warranted. She reports forgetfulness with multiple daily dosing, so perhaps we could look at the ditropan from TID and put her on the extended release formulation, and always monitor for blurred vision and dizziness associated with these agents. Monitoring, follow-up, and education, I would definitely go with close, frequent monitoring and shared decision-making throughout. Monitor her adherence and side effects, especially with metformin, GI. She's suffered a weight loss, so I wouldn't want her appetite to be affected. Plate method education might help this patient. And always watch out for hyperglycemia and help her to self-manage as much as we can. As far as quality of life and maintenance, isolation is definitely an issue here with this patient, so I would definitely reach out to community resources, senior centers, and nutritional support. I would also investigate and assess food insecurity and consider a referral to a dietitian. And as I mentioned before, the International Council on Active Aging has that map that you can locate appropriate resources for your patient. And this activity and physical activity and good nutrition help support that health status and cognitive function. Next slide. With respect to basal insulin, all the doses should be switched from bedtime to morning. If the patient is on pre-mixed insulin, 70% of the total daily dose should be given in the morning. And the titration of basal insulin should be based on fasting finger sticks over 1 week. Our goal here is between 90 and 150. Remember to individualize the targets based on their health status, presence of comorbidities, what is their social support and living situation, what is their cognitive status, their functional status, and ability to self-manage, presence of symptomatic hyperglycemia or hypoglycemia. If half of the fasting finger sticks are above goal, increase by increments of 2 units. If 2 or more are below 80 milligrams per deciliter, decrease by 2 units. Next slide, please. Simplification of mealtime insulin applies whether the patient is on basal insulin or not. Just follow the guideline for basal insulin. If mealtime insulin dose is more than 10 units per dose, decrease dose by 50% and add a non-insulin agent. If mealtime insulin dose is 10 units per dose or less, you can discontinue the insulin altogether and add a second-line agent. Aim is to discontinue that insulin and titrate it down, of course, as you optimize the dose of the non-insulin agent. Your non-insulin agents are your metformins, your GLP-1s, SGLT2s, and the rest of the oral agents. Consider metformin first. As long as their renal function is up to par, you can start at the lowest dose possible and titrate upwards every 2 weeks. 500 milligrams daily and titrate every 2 weeks to the maximum tolerated dose. If metformin is not tolerated, if the patient is already on metformin, or if their GFR is compromised, consider a second-line agent with special attention on renal function if they are renally impaired. Next slide. Additional considerations and tips is never use any kind of insulin at bedtime. This is a recipe for disaster. If you must use a sliding scale, make sure it's very simple. Here, the guideline presents a very simple recommendation. If it's more than 250, 2 units of short acting. If it's more than 350, 4 units of short acting. If not, discontinue the pre-meal insulin altogether. Follow up with the patient every 2 weeks to either adjust insulin and or medication doses. I have to tell you here, sometimes I would have to follow up with my patient more frequently than every 2 weeks. It really depends on that cognitive function, that health status issue, how sick is your patient. Use your clinical judgment. Base recommendations on glucose readings over 2 weeks performed before lunch and dinner. Always individualized, and we want to see 90 to 150 milligrams per deciliter, but adjust that goal based on that patient's overall health status. If 50% of the pre-meal finger sticks over 2 weeks are above goal, you can go ahead and increase the insulin accordingly or add another agent. Beware of hypoglycemia. If 2 or more pre-meal finger sticks are below 90, reduce the dose of the insulin. Next slide, please. So here's just an overview of a pharmacologic therapy. Of course, we have high efficacy with metformin, GLPs, TZDs. Hypoglycemia should always be our focus. You have your secretagogues and insulins are the highest risk for that. And you should always watch for combinations of medications. The more medications we combine, the higher the risk of hypoglycemia. Weight change should always be on our radar, especially with those agents that can increase those GI effects and affect appetite in our elderly population. Cardiovascular benefits should also be on our radar if possible. Cost Also, of course, the lowest with our oral agents, metformin, TZDs, and sulfonylureas. Look at your patient preference. If they don't want to do it, general rule of thumb here is they're not going to do it, and they're going to be non-adherent. Always look at the pharmacokinetics in your patient. Do they have hepatic dysfunction? Do they have renal dysfunction? Of course, those are all things that we should look at with our medication recommendations and adjust those doses accordingly. Additional considerations are with metformin, of course, if their GFR is below 30, we should be looking at GI, as I mentioned, bone fractures, risks of falls here is very important. Genital urinary infections and increased LDL have been seen with SGLT2s and TZDs. Pancreatitis we all know about with GLP-1s and DPP-4s, and there is a high risk of a higher risk of heart failure among TCDs. And we should also always look out for injection site reactions with our injectable pharmacologic agents. Next slide, please. Here we have another patient case. Her name is Consuelo. She's 82. She's Hispanic. Her A1C is 6.7%. She's got a history of hypertension, hyperlipidemia, osteoporosis, urinary incontinence, mild to moderate dementia. She lives with her daughter, excuse me, and her family, and her daughter is her main caregiver and oversees her mother's medications and overall care. Her daughter goes with her to all of her medical visits, and she explains that her mother has progressively functionally declined since the death of her father 2 years ago, and that is the reason why she brought her to live with her in the United States. She helps her mother bathe and cares for all of her personal needs, including dressing, hair, nails, makeup, as well as administration of all of her medication, including her insulin. The daughter works part-time, has limited English proficiency, and also cares for 3 young children. Her husband mainly provides financial support. Her other issues here is that she has fallen. She has many out of range readings, and her blood pressure is 110/74. This is her insulin regimen. She has insulin glargine along with this insulin aspart, along with the rest of her medications. Next slide. What critical areas of concern regarding this patient case would you focus your interventions on? So definitely all of the above. Let's move on to the discussion on the case. So in this case, I know I didn't read it, but the daughter was checking her mother's finger sticks 5 times daily. She definitely has readings below 90. I would definitely reduce that premeal insulin by 50% and switch the dose of basal from bedtime to morning. She does have mild to moderate cognitive impairment, and she has dependencies on ADLs. So I would be more comfortable with a target closer to 8 to 8.5 even. I would definitely start her on a low dose metformin and monitor for side effects. And the goal here would be to discontinue the premeal insulin altogether. Cost is definitely a huge issue. I would look for ways to help this patient switch to generics where possible. Other potential effects are are at history of falls. Syncope again is an issue here that I would target. I would target a goal closer to 140 over 90, maybe even a little closer to 150 over 90, and reduce the dose of lisinopril. Hyperglycemia, hypoglycemia, and close monitoring and shared decision include the caregiver. She's the one that's taking care of her mom, so she needs to be included in all of the education and needs to agree and be on board with everything. As far as quality of life, definitely look for your community resources here. Tie her into anything that can help her afford those medications as well. 340B, anything that can help the patient with the cost, and see if she's eligible for Medicaid as well, and get her into some sort of socialized exercise, physical activity program that you can connect to. Next slide. In summary, the seniors have the highest level of prevalence with respect to diabetes. In our professional lives, we are very likely to encounter this population. It was my biggest population where at Zufall, where I practice. More likely to be complex and even very, very complex with multiple comorbid conditions and risks associated with the complications of diabetes. Polypharmacy is big in this population. They have multiple illnesses. If we can de-intensify, simplify complex regimens, that's definitely the way to go. Always look at how sick your patient is. How many complications are we dealing with? Can we include their caregivers? What adverse drug events is the patient experiencing, or what potential adverse drug events may they experience moving forward in their care? Simplification and de-intensification to avoid hypoglycemia should always be our focus. We need to reduce the caregiver burden, the patient burden, the distress, and improve adherence as much as we can and is reasonable. Self-management education, community resources, proper nutrition, social support are beneficial and have been shown to improve their quality of life and help preserve the health status, cognitive and functional abilities. And it also helps preserve, support their caregivers and families. Thank you so much for joining us today, and I hope that you enjoyed the presentation.
Thank you, Terry, for your presentation. We are just going to remind the audience that we have session number 4. This one is going to take place on June 12th at 1 p.m. Eastern Time. And we are going to discuss motivational interviewing and diabetes care. So everybody is welcome to join us, and please make sure that you attend this session number 4, which is the last one. And we are going to have, in addition to Terry, a motivational interviewing subject matter expert. So we hope that you can join us on June the 12th. Next slide. So we are going to start our Q&A. Before we get into the Q&A session, I just want to remind the audience to please complete the survey at the end of this activity. Your feedback is really important to us and provides recommendations on the next activities that you would like to have on diabetes or any other emerging topic. So if you have any questions or if you have anything to add, please use again the chat box. You can type your question or you can use the raise hand icon and your line will be unmuted. We're going to give some few seconds to see whether we have any questions. Please remember that after this webinar, you are going to receive an email with the location, with the link to the recorded version and the slides and other resources and handouts from the panelist, Terry Lawson. Any questions in the queue today?
No, not at this time.
All right. And so, Terry, in regards to chronic medical conditions, and it's very difficult for some patients, you know, over the age of 65 to keep track of all the medications that they are on. Is there any recommendation, you know, from a pharmacist perspective on how patients or how pharmacists can help patients to keep track of all the medications that they are on?
Well, definitely, I used to do an adherence sheet. I called it an adherence sheet. I believe I presented it in the first presentation that we gave. It's sort of a list of medications for them, but it also indicates when to take the medication and what the medication is for. It was language and language based, so it was in English and in Spanish, and it also had universal symbols with you know, the sun coming up for the morning and up in the sky at noontime, so it would give them like a visual. It also had clocks on it, so anything that could help provide some level of or memory tool for them, it is something that can definitely help. And I found that to be very helpful for my patients. I would also combine that with a pill box. At the time, we would get free pill boxes. I believe it was BD that donated them. And I always used to give them out to the senior population, especially those that had issues with their memory. So basically anything that will help your patient with complex medication regimens, even phone alarms or watch alarms, anything that can help them would be beneficial.
Thank you, Terry.
You're welcome.
Any questions, Elaine, in the queue?
Yes, we have one question, and it says, would you consider offering CEUs for this type of presentation in the future?
And I believe that as an answer, I mean, that's a question that I can answer. The response is yes. We are considering offering CEUs for our next sessions. So next time when you receive an invite to attend any of the invitations, or any of these sessions, then you will receive information about whether or not CEUs are available. Thank you for that question. Now, Terry, another question. This is in regards to COVID-19, and probably I will put you on the spotlight for a moment. You know, most of the health centers are offering virtual visits. You know, either they are having conference call with the patients or they are doing some kind of telemedicine. You know, so, you have a patient, you know, an elderly patient, and you have a conversation as a pharmacist with them. What would you make sure that the patient understands during this COVID pandemic? Either would you go over side effects, or making sure that the patient is taking the right medication at the right time? How would you conduct these virtual visit from a pharmacist perspective?
Well, from my perspective, obviously, COVID-19 has impacted the way that we can all reach our patients, and telehealth is definitely a very reasonable way to go, especially with this patient population. Um, we're talking about people that are at a very high risk of fatality if they get infected with COVID-19. So one of the main things that I would focus on in the beginning would be, let's take a look at your medications. I would still have them do, bring out their medication bottles. I would still discuss with them anything that was, pointed out, if you will, from that medication review, and conduct the visit as the same as I would conduct it, you know, physically. I would do the medication review first. I would probe to see how the patient is doing with their medications, if there's any new barriers that have come up, especially in the arena of COVID-19. Have they experienced any new barriers with acquiring their medications, for example, or getting their medications? So uh, that's one focus that I would have at this time, and really virtually conduct patient safety uh, interview throughout the course of the session.
Excellent. Thank you, Terry, for your response. Let's check if we have any other questions from the attendee. Any questions?
No.
No. All right, and I just have one more question, Terry, and the question is regarding. I mean, let's move from the pharmacist perspective and see this as a diabetes educator. Is there any difference between providing education to a young patient or an adult patient and someone who is over the age of 65? What would be the difference, and what would you make sure that you would address, when you have this conversation with a senior patient?
Well, for sure, my focus there would definitely be cognition, depression. How isolated is this patient? Unfortunately, our senior population do have a tendency to become depressed. They have a lot of chronic conditions that they have to deal with. From a perspective of a diabetes educator, just looking at diabetes alone is distressful to the patient, right? And there's many medications that may be on board just with respect to diabetes. And then they have their other comorbid conditions, such as urinary incontinence, which is very common in the older population, that can also cause distress and further the risk of depression, or worsen depression even further. So definitely, if with respect to the difference between dealing with a young person that has no cognition decline or functional disability of any kind with diabetes versus a patient that is over the age of 65 and has diabetes, I would definitely focus on that cognition, that functional ability to self-manage. Would be my different approach, if you will, between the two age groups.
Excellent response. Thank you, Terry. One more time. Any questions in the queue?
No.
No? Okay. So I just want to remind the audience that we have another session. This is going to be on motivational interviewing. This is going to take place on June 12th if I'm not mistaken. So please make sure that you attend. It's going to be an honor to have all of you attending our fourth and final session. Next slide. So please make sure that you complete this survey after the webinar is over, and remember to visit our website, www.nchph.org. You will find publications, information on upcoming events, and other information regarding one-on-one training. Next slide. We have new publications. You can go to our website again, and next slide. You can also join our mailing list. You will find information on HRSA updates, funding opportunity, senior programs, upcoming webinars, and other resources. Next slide. And you can also contact any of our staff members. You have any questions, you can go to our website and you can use the TTA request form, or you can contact us directly. Phone number 703-812-8822. One more time, 703-812-8822. Thank you so much for attending this activity, and have a great weekend. Thank you.
Thank you.